Emily and I are going to kind of tag team a PowerPoint here. Yeah, this works. We can go backwards. Okay. Progress. So, we were here about a year ago, and I think most of the time we spent last time was on, what's really in the waiver, what evidence we have from other states, what are the programs that we have to look on as precedent. All right. Yeah. I got excited. Okay. And so, this year I think we wanted to just sort of step back and look at it more broadly, and then hopefully offer some updates on things that have been happening more recently. So, we're going to go through a timeline later, but just to sort of set the scene, of course, we expanded Medicaid in 2014, and that's been moving right along. The waiver was in 2016, they made some changes in 2017. It was approved in January. Of course, 16 Medicaid enrollees sued. A judge stopped it June 29th. They reopened the comment period. That is now over, and now we're that's kind of where we find ourselves now with Medicaid. I'm going to go through a little bit of background on, where we are now and how we got here, and then we'll kind of move into some more specific. So the first thing I want to show is really the good work that the sisters did and many others following the expansion. Our uninsured rate, as everybody knows, plummeted. And I split this up between metro and non-metro counties to show that the gap between people who live in rural Kentucky and urban Kentucky has shrunk. There's still a gap, but it's much smaller than it used to be. And that's really important, I think, especially since we're focusing a lot on rural America lately and rural Kentucky specifically. For us, I think it's important to show that has made a big difference. As of February, we had 1.4 million Kentuckians on Medicaid. There were 911,000 on traditional, and just shy of 500,000 in the expansion. The expansion population has since gone down. We'll talk a little more about that later if we want. But suffice to say, most of what happened, and I've got a slide later to show this, most of what happened with our uninsured rate is thanks to Medicaid expansion. And so, what that meant was there was a commensurate change in what happened with hospital finances. This shows charity care and self-pay charges in Kentucky's hospitals. It plummeted by 67%, which really goes to show that two things were happening. One, more people were going to the hospital and were able to get their bills paid. And two, of the people who were already going to the hospital, they had coverage now. They could pay for it. They didn't depend on charity care and hospitals didn't have to do self-pay, which often ends up either in sending that off to, for reimbursement or, writing that off. And because there were better hospital finances, really helped the economy in Kentucky. This shows job growth from December of 07, which was, sort of the bottom of the recession, the financial recession, for healthcare jobs and all the other jobs in the private sector. So, healthcare generally is a pretty resilient sector, as you all know. The rest of the economy sort of bottomed out in terms of, labor by early 2010, and then started going up. But it's harder to see there just because it's stretched out a little more, and because the words are completely illegible below that, is that it picked up after Medicaid expansion. It was already outpacing the rest of the economy, and then it really picked up. And so they've added close to 16,000 jobs since 2014, which is a higher percent growth than the rest of the economy. What's important about that is that doesn't just affect people who work in healthcare, that affects everyone because, in economics there's something called the multiplier effect, which basically says when you put a dollar into one industry, that money circulates in the rest of the economy in specific ways. And we know with healthcare, it has a multiplier of 2 to 4, depending on what you're looking at. So for every job created in the healthcare industry, 2 to 4 jobs were created outside of it. So this really helped. And it makes sense. If you pay somebody to do healthcare work, they go out and they buy clothes, and groceries, and services, and cars, and they pay for rent. And so that money is then used to do the same thing with other people. And so, these jobs really are community jobs, and they're very helpful not only for the folks who immediately benefit from them, but in the broader economy. And that, helps especially get us out of sort of the jobs trough that we were in. The other thing that goes along with that is that people have been accessing care more often. And I know that's sort of a wonky term, but you all have seen it, I'm sure. People were able to get to the doctor. This shows the per person per month spending for all Medicaid enrollees going back to 2012, where it was decreasing a little bit, and it jumped up in 2015, which you would expect because a lot of people got coverage for the first time. They had a lot of pent up problems. They had a bum knee or they had a weird cough or whatever, and they wanted to go to the doctor to get it checked up. And so that next year, they were getting care, and studies show that people were getting care for chronic conditions. They were going to routine care. They had a primary care physician. And so after that initial bump, when they were using that care, started to drop. Sort of contrary to what we've been hearing about, skyrocketing growth in healthcare costs, which is true, but Medicaid's a better sort of value in terms of healthcare spending. Medicaid's a better value. And as people got healthier, they started using less of that care. And so, they were going to the doctor more. That translated to better health outcomes, so the preventable hospitalizations for things like hypertension and asthma started to decrease. Breast cancer deaths started to decrease. Infant mortality started to decrease. More people started reporting excellent health. Fewer people were reporting fair to poor health. And so there's been a lot of evidence that, we're really making progress in terms of our health because more people are able to get to the doctor when they need to. It is only 20% of health, care. And I think that's totally, if you look at the rest of the 80%, that 20% is very important. And I think it's really starting to show up. The other thing I wanted to say is that, you hear a lot about, especially with this waiver, the idea that we want to get people back to work. We want to get people on the job. We want to make sure that people are earning a living and contributing and all of those things. I don't think anybody in this room would disagree that those are values that we all hold. But if you look at what the data says, most Medicaid enrollees are working. They just work in low-wage jobs. I can't remember if I included a slide on this later. I guess we'll find out. But they work in jobs like construction, retail, restaurants, jobs that are notoriously low wage. And those are also jobs where scheduling is really inconsistent. And Emily will get more into that later. But if you've ever worked in a retail job, there are things like just-in-time scheduling, where you may be told the day of you need to show up for a shift, or you might get to work and say, we don't need you. It's almost impossible to plan out 2 weeks in advance or however long so that you've got childcare ready for that or whatever else. So, this work is by definition low-wage work. That's why they qualify for Medicaid to begin with, because they're earning below 138% poverty. But I do think it's important to mention that. Those red boxes at the bottom, that's sort of a bunch of categories lumped in together. But the one category in there that I think is important to mention is other, which just means they weren't working full-time or part-time. They weren't looking for work. They weren't ill or disabled. They weren't retired students or caretaking. And we don't know why, which means essentially that's the population that the entirety of the work requirement is focused on. It's that 1.3%. So that's an important thing to keep in mind as well. Oh, okay. So there you go. They're working in sectors that tend to have inconsistent schedules. One interesting thing on here that I noticed was elementary and secondary schools, and I didn't really understand that when I pulled the data. But then we read through all the Medicaid comments recently. I'll talk about that in a minute. And the substitute teacher said that she's on Medicaid because, it's very hard to get consistent work as a sub. It's very hard to make ends meet when you have that. You don't know when your schedule is going to be. And so, I'm sure there's more than just substitute teachers who are on Medicaid, but I think it's worth, thinking about what is the reality of the folks who are utilizing this type of coverage. What kind of lives do they lead? What kind of work are they in? And then how do we support that rather than penalize them for it? So, again, I'm going to let Emily talk more about the waiver later, but it is important, I think, to mention that, the state estimated that there would be 97,000 fewer adults covered. You hear 95,000 thrown out a lot. That's because they anticipate a slight increase in kids being covered, and so it's knocks it down to 95,000. According to their estimates, it's 96,687, which is this number that you cannot see because it's too far away and too small. But I think when you look at what that means in terms of the actual people in each county, that ranges from anywhere between 0.7% in Oldham County of the population losing coverage to 4.5% in Owsley County losing coverage. And of course, most of the coverage losses are going to be in Eastern Kentucky because that's where most of the gains were in coverage. I have another map that I've not included here that shows the reduction in the rate of uninsured on a county-by-county level. And it was across the board, more people got coverage, but Eastern Kentucky really was the big winner when it came to making sure that people had coverage. Now, of course, more people in Jefferson County and Fayette County got coverage and were covered by Medicaid. But in terms of a percent of the population, it really was Eastern Kentucky. I can't go backwards. What's that?
The non-expansion.
Oh, yes. Yeah, that raises a great point. So, what you hear a lot of times is that, the administration anticipates it's going to be a lot of the folks on the expansion. And again, the picture I would say they like to paint, that I've heard them paint many times is, you have these folks who are sitting on their couch getting rich off of their Medicaid card, really being able to take advantage of the system that way. But in truth, that only accounts for about 2/3 of the total that are going to lose coverage. There's 20,000 who are traditionally eligible, which we've determined are mostly parents, low-income parents who are going to lose coverage under this. And there are ways for the low-income parents to lose coverage. That's actually where most of the savings come from, the waiver too, I should add, or at least the plurality of it, because the match is less generous, and so the state ends up paying more per person for traditional coverage than expanded coverage. Here's another slide you can't see. This is a slide that kind of breaks down what we already know coming out of Arkansas. So Arkansas was the first state to implement their work requirement. So far, they're the only state. We were the first to get approved, but they beat us to implementation. They essentially just piggybacked off of the SNAP work requirement, what used to be called food stamps, as you all know. And they have found that most people don't have to report because they meet certain criteria. The first month, there were supposed to be about 10,000 people required to report some kind of activity. A few had an exemption. It's not clear whether or not they actually received the exemption. 29%, which is the overwhelming majority, I think it was 8,000 of the 10,000 didn't report anything at all. And only 2% reported something. And of the 2%, only 72 people actually reported work hours. Most of them just reported that they met the SNAP work requirements, so they were eligible. So, the lesson I think out of Arkansas is that even when it was a very simple sort of mechanism for enforcing the work requirement, it was still very difficult for people to do, largely because the only place to do that was online. You couldn't call in, you couldn't go to local office, you couldn't mail in any kind of thing. You had to do it online. And what we've learned from the proposed regs in Kentucky is that they're planning on doing the same thing. Good question.
What will we do about areas that don't have access, to computers or to be able to do that?
It's a great question. There's an 1115 waiver form on Thursday, and they'll be there first to answer some of those questions. I mean, we've asked those questions. What they've said in the past is, there are libraries in those communities, and we really hope that people can get to those libraries. We're working with them to partner and make sure that they have access to computers. But we also know that there's 40,000 Medicaid eligible adults who don't have access to transportation, right? Largely in rural parts of the state. And so, that is the big question. And it was kind of a shock to us to learn that they plan on only accepting electronic inputs for activities for any of this reporting. And so I think that's going to be, if this gets approved again, and I think it will, and they implement it, I think that's going to be a really big barrier. Yeah.
So the other work that the state has been doing is to build an app where you can report through your phone or on some sort of mobile device. And I think, that is probably going to be more accessible for some people, but obviously you have to have data or Wi-Fi for that. But the other element of this is that you have to have justifying, you don't necessarily have to, but if you are audited, you would need some documentation to back up what you're reporting. So if you wanted to report a screenshot or some sort of document that shows your hours, activities, then you have to upload those things. And right now, the file upload was limited to PDFs. They've expanded the different types of files, but it's still 2 megabytes. Or
2
gigabytes?
megabytes.
Megabytes.
Yeah.
I don't know my bytes. But it's not enough.
Right?
It's not enough for most images. We'll just leave it at that. So a lot of images need up to 4 or so, just for really typical sort of images that you would be uploading. So that's another way that someone can try their best and it still doesn't end up working.
But they still be, the onus is still on them.
Right.
That's right. This was the chart I mentioned earlier. The point I'm trying to make here is that when we expanded Medicaid, there wasn't much of a change in the individual market. There's a little bit because, I think it was around 100,000 people initially were able to get coverage through Connect and now healthcare.gov. There really wasn't much of a change in employer coverage. It sort of rose and then fell again, but it stayed pretty stable this whole time. What was dramatic is just how the number of uninsured, the number on Medicaid within the, I polled people who were essentially Medicaid eligible under the expansion. It essentially flipped. It mirrored itself. And so, what's concerning to me is that there's a lot of hope, I think, or at least a lot of rhetoric around how when we implement this waiver, there's going to be a lot of opportunity for folks in this income category to either raise their wages and end up with employer coverage or coverage on the exchanges, or employers are going to be willing to start offering that, and then we're going to move folks off of Medicaid and offset the cost of employer coverage. And then, if history so far has been any indication, I don't know that that's going to be possible given what we've seen so far. So, like I said before, the comment period ended on August 18th, and so Emily and myself, Kara Stewart, and Angela Koch spent a week sorting through 5,300 comments. There were 11,500 submitted, and I went in there and pulled out all the duplicates. There were a lot of duplicates. I think there were 200 comments that were duplicated at least once. One of them from a cystic fibrosis patient was duplicated 1,400 times. So they just got really like that. So anyways, I pulled all those out. There were 5,300 unique comments. And we sorted them by, were they unsupportive of the waiver, were they supportive, were they mixed, or were they unrelated? And unrelated, there were a lot of NAs, or this won't affect me. And honestly, a lot of those came from comments that we had collected through a survey and just ended up getting submitted anyways. Mixed were, both sides. I can maybe, for example, they would say, well, I'd be willing to pay a small premium, but it seems like a lot of reporting and I don't really want to do that. Or organizations who said, well, I could see why you would want to try and encourage people to get better jobs, but I'm not sure this is the right way to do it. And, so we were pretty generous with that. Supportive were individuals or organizations who were pretty unequivocal about how they wanted this waiver to be accepted. They would urge CMS to approve it. They would talk about why they thought premiums or that would be good. Or there were stories from folks who said, I'm already doing this on my Medicaid, no big deal, go for it. But there were 8,472 comments that met any one of the following categories. Either they spoke very highly about what Medicaid has meant for them or their community or their loved one, and they wanted it to stay the same. People urging CMS not to approve it, or people who really had a lot of evidence to show why these barriers to care really would result in people becoming uninsured and potentially less healthy. And there were, if you want to go on Twitter, I know that's normally a dangerous place to live, but there are some really interesting stories that I've posted and Kara posted out of there. You search for hashtag KYSays, we probably tweeted out a couple hundred of them. They really were compelling. People had a lot of really powerful testimony about what Medicaid meant for them and what they think is going to happen because of this. I was frankly surprised by the level of understanding people brought to the table about their situation and how these changes would impact their particular situation. A lot of people talked about what it would mean for them to lose dental vision and transportation. So, you know, to put this in context, the number of comments, the waiver that has I actually went through, there's been 1115 waivers. Sorry, that's confusing. And I went through and looked at all their public comment periods. The one that had the most was a waiver out of Texas last year. They had 18,000 comments. The next three largest number of comments on waivers were all Kentucky Health. This one, and then the next one was the open comment period from 2016. The one after that was 2017. So it was 11,500, 1,800, 1,200. The next most was Ohio at 600. The average number of comments was like 273, and there were over 70 comment periods for which there were none. No one commented on them. And so I say all that to say, you know, this has generated a lot of attention. People care about it very deeply. They're concerned. It's got a lot of national attention, and I think for good reason. So I think that's it for me. I'm going to hand it over to Ed.
Right. Should I stay here?
Sure.
Yeah.
Well, I was going to get
All right. So I wanted to talk.
What did you do?
Nothing. Don't. Yeah. I wanted to just kind of go and give a little background about 1115 waivers. If you weren't here at the last meeting that we spoke at, or if you just need a little refresher, these waivers are really intended to, you're essentially asking the federal government to allow you to make changes to the Medicaid program in your state in ways that would increase access to care, improve health outcomes, reduce administrative costs and burdens. And you're demonstrating that you can do this essentially better than the regular Medicaid program. That's the point. It's a demonstration. They're typically 5 years, and they need to be budget neutral. So you can't spend more money to make these changes. You need to do it within your regular budget, but the federal government can tell you, sure, you know what, typically we don't allow you to charge premiums, but you've made a good case for why you want to test that out, and we're going to allow it. Well, they've actually already done that with some other states and have found so far that premiums are a barrier, that they're not improving access. It's not something where you're, engaging people in a way where all of a sudden their healthcare is more valuable and therefore they take advantage of it in a more significant way. That's just one example. But we can learn things from these waivers. But then as you're learning these lessons, that should sort of be a feedback loop where you realize what is working, what isn't working, and that informs the way that you run your programs and change policies. So this is a timeline that I think is probably also going to be hard for you to see. We'll make sure that Mona gets these slides so that you can share them electronically with folks, because some of the colors I know are also a little tough. But you can just see here some of the major decisions and different points in time that have sort of been in the progress of this Medicaid waiver. It started, actually, we don't have 2015 or 2016, I should say, on this. Oh, it's right here. But that's when this was originally, developed, and then it's progressed over time. We've had 3 federal comment periods now. As you probably all know, I would guess, heard maybe in the news, media, or know because of the industry that you work in. Back in June, on June 29th, the day or the Friday before, the Medicaid waiver was supposed to go into full implementation. The Judge Beauregard, who's a federal court judge, he blocked the waiver, saying that it did not meet the requirements of Medicaid program or the scope of the Medicaid program, which you can read his 80-page opinion, but generally he says it is to improve access to care and to furnish medical assistance to low-income Americans. So I won't go through all these different points in time, but I will say that something that I think has given us all pause and has also illuminate it is what happened right after that court decision. The state decided that, if we can't implement the Medicaid waiver as we were planning to, we're going to make some other changes. We're going to enforce copays, which were optional previously, and we're going to reduce benefits for Medicaid expansion members that are optional. And some of those benefits include transportation, non-emergency medical transportation, dental, and vision. And so, effective immediately, with no notice to Medicaid members, no notice to providers or anyone else working in the Medicaid world, people lost these benefits overnight. And while they were intended to it was intended only for the Medicaid expansion population, it ended up affecting others as well. So these are things that we often see with major policy changes that, we're so reliant on systems functioning correctly, really complicated computer systems, being able to integrate information and work in real time, and having MCOs communicating with state agencies, communicating with provider offices. And when something doesn't work, whenever a piece of that whole system doesn't function the way that it should, chaos can ensue. And that's exactly what happened the first week of July. People who shouldn't have lost benefits were losing benefits. Pregnant women, children, the state might say differently, but they did unintentionally lose benefits because the screens that providers were seeing were telling them that their coverage was not active. So I think that this is just a little bit of a cautionary tale for us to remember that when we make these huge changes, there's a lot of confusion, a lot of complexity, and systems can malfunction. And then if we don't have good plans in place, people end up getting hurt. So we want to avoid that at all costs, of course. And so in terms of our concerns, regarding these barriers to Medicaid coverage, we have a number of concerns. I already mentioned that premiums do reduce coverage. We have a lot of evidence that academic research, evidence for other states that have tried this, that show that, it does create new barriers to care. Cost sharing generally, so that includes copays, for instance, decreases use of necessary services. If you have a chronic illness and you have multiple medications and you have multiple specialists that you have to see every month, you have to start budgeting for that. And at some point, if you don't have the money to pay that upfront cost, you have to make decisions and ration your care. And we never want to see people rationing necessary care. So there's, of course, limited understanding of complex incentive programs, and these programs are really complicated. Just to create your account to use the Benefine system, which includes now what they call the Citizen Connect portal, which is all part of Kentucky Health, a way of online access to these different components of the program. There's a 29-step guide, I believe, and then other documents that are explaining different elements of this program are just multiple pages, very complicated, and it's hard for people who do this every day, like me and Kelly, to really understand all these ins and outs and how to help someone with it. But if an individual is just going online themselves at home and trying to understand what they need to do, it's almost impossible. And we've actually helped to test out these systems, especially the Citizen Connect portal, helping people to create their accounts. And there are lots of opportunities to fall through the cracks. So increasing documentation requirements decreases coverage. We know that the more you require to be reported, the more time consuming it is, or if there are limitations in how it gets reported, then it makes it harder for people to just sort of manage all of that and to meet all those requirements, even if they're doing all the right things. And so one of the things that I often say is people are trying to do the right things, but because it's complicated, because it takes all these extra steps, they often aren't able to prove that they're doing all the right things. So we really don't see this as an issue of whether or not work is valuable, or we're not debating the merits of work. We think that the requirements are going to outweigh any of the benefits. And there are lots of ways to use Medicaid as a work support that actually helps people be healthier and more able to work, more employable, more productive, and we want to focus on that. And then many of those who are sanctioned or penalized of your work requirements should be exempt based on a disability. But those exemptions aren't automatic. You have to initiate that process. You have to document things. You have to go maybe to a doctor's appointment and make sure paperwork was not only filled out, but processed correctly. You have to wait sometimes to get that determination. And in the meantime, you might be having to still pay a premium, having to still meet requirements, reporting requirements, and doing all of these other things. So we can't assume that just because you are eligible for an exemption that you're going to get one. So then when we think about these coverage losses, there's a lot, as I said before, a lot of research, a lot of evidence from other states that already can give us an indicator of whether or not it'll work. And so we know from, for instance, the Kaiser Family Foundation that they estimate implementing work requirements that have a lot of that reporting requirement will mean that 1.4 to 4 million people nationwide could lose coverage. There are other projections from states like Kentucky, it's 15%, Virginia 18%, where they're really seeing the same thing. So we're hearing over and over, fewer people are going to have coverage. There's no report, meanwhile, that says how many jobs are being created that will be higher paying with better benefits to support these people losing Medicaid coverage.
This is with the Kaiser.
Sure. Oh yeah, it's good.
One thing about the Kaiser estimate, it was really interesting. If you all have read it, I encourage you to. It's pretty readable. But they took different scenarios. That's why it's a range of 1.4 to 4 million. They took different scenarios within, the work requirement or the community engagement requirement. They actually used Kentucky as sort of a model requirement, and then they made different estimates based off different scenarios. And in each of the scenarios, what they ended up figuring out was that most of the coverage losses don't come from people who can't keep up with the requirements, so aren't technically meeting them. They come from people who get tripped up in the paperwork to prove that they've met them, which I think is a really important point and something that, if this does get approved, something that we should think about as we try and help people navigate it. But I also think that goes to show that this really increases what Jason Dunn calls the hassle factor. That when you ask more of people along the way, there's more opportunities for tripwires. And that's really what I think is going to result in the largest coverage losses here.
Yeah, absolutely. And even if you're able to prove that you did these things and somehow wasn't processed correctly, or you're able to get things in after you lose coverage, the onus is still on you to get the process, to get your application fixed, or to get your coverage reinstated. And working with the system, calling into the call center can take you an hour, 2 hours on hold. Some people don't have the time during the day to wait, and sometimes your call gets cut off. Other times, you have to go into an office and you sit there for hours waiting to see someone, especially when this is happening on a grand scale, because everyone's having trouble. It's just impossible to get through. So these are the areas where we really want to reduce barriers, not increase them. And then why people lose coverage, Dustin really already talked about this. Fluctuating work hours, unpredictable schedules, seasonal work is a really key issue for us, because when you're making all of your money in half a year's time, your eligibility should be based on an annual income. But sometimes, depending on how you report that income and who's processing it, they might say that you're no longer eligible and you get kicked off coverage until you get the right person to straighten things out. That my sister and her husband are farmers in Indiana. They have 3 little girls and they're on Medicaid expansion, and that's happened to them. So other barriers are transportation. We already talked about all of this, the complexity, exemptions, and people who don't necessarily even understand what the requirements are or what they're eligible for in terms of exemptions. So I think a lot of people in Arkansas didn't even know that they needed to report, number one, or two, how to do it, let alone weren't able to then, follow through and complete that successfully. So who is going to be subject to these new requirements? This is something that we covered last year, so I don't want to spend a lot of time on it. Things haven't really changed. Some minor changes, actually, for certain populations, especially in terms of exemptions. But basically, the people who will participate, it's the majority of Medicaid members, about 1.2 million, are on this side. People over the age of 65, people receiving SSI, living in long-term care facility, current foster care children, and there's a breast and cervical cancer treatment program. Those are all exempt. They're completely outside of their Medicaid coverage is outside of the waiver. And then anyone who's enrolled in the 1915C waiver, those are home community-based support waivers. Those individuals also completely separate from this program. So most adults are going to have some sort of change. And that could be a change in their benefits. It could be a change in things that they're required to do. But what you'll see here, and we, when Dustin was talking about the people on traditional Medicaid who lose coverage, it is primarily parents with dependent children. That's the pocket category, PACA, and their income, for eligibility. If you remember pre-expansion, how Medicaid was in Kentucky, it wasn't very generous for parents. You had to have an extremely low income, and now it's even lower. So it's about around 25%. It ranges from, I think, 24 to 28% for parents with dependent children. That's your income of the federal poverty level, I should say. That would be the maximum that you could earn and still be eligible for traditional Medicaid. So if Medicaid expansion goes away, then individuals who are above 28% of the federal poverty level, even if they have kids at home, may no longer have coverage. And then, of course, there's the expanded Medicaid population, and they're going to have the most impact. But what you see here, if you want to take a look at home, is the household size, and that tells you what eligibility category you fall into. A lot of people forget that Medicaid expansion adults actually often have kids. They're the ones that have incomes above 28% of the federal poverty level. So there are 4 main benefits that are eliminated by Kentucky Health by this waiver. And again, it's for those different populations, primarily Medicaid expansion, but dental coverage, vision coverage, retroactive coverage, which means maybe you had a gap in coverage, somehow you lost your coverage. It could have been an accident, it could have been a paperwork mistake, or it could be that you just didn't file something in time, but you have some time where you're uncovered. And typically there's a 90-day retroactive coverage where you're able to get your coverage reinstated. The state will pay for that care that you received whenever you didn't have active Medicaid coverage, but they're taking that away under this waiver. And so that's important for people who may need to seek care when they don't have coverage for these times when the system isn't working properly. And providers can say confidently, I know I'm going to get paid for this if I just wait and hold the claims for a few weeks, so I'm going to see you anyway. But if they don't think they're going to get paid for it, they mostly have to make the decision for their financial interests to turn you away. So we don't want to see that happening. And then it's also really good for hospitals. If they find out you're eligible while you have a hospital stay, they're able to then help you enroll in coverage, and that helps them cover their costs and keep their uncompensated care down. So, and then the other benefit is non-emergency medical transportation, which I mentioned. And of course, that's an excellent way of reducing barriers to care for people. And it's really low cost. It's a minority of the population that uses it, and you actually have to prove that you don't have reliable transportation. So it's not something that's being misused. It's only for going from your home to a medical appointment. You can't take a Medicaid cab all over town. So this is really a service that we think is vital and makes a lot of sense. I'm sure there are more administratively efficient ways that you could manage it, but I don't think that the solution has to be taking it away. And then there's a My Rewards account that's being created so that you can earn back certain things, dental and vision services, but you can't earn back the other 2 benefits. And you're not actually earning a benefit at all, you're just earning fee for service. So if you were to go to the dentist and you need $300 worth of work, but you only have $150 in your My Rewards account, the dentist is in the position of either only giving you $150 of service, of turning you away, of eating the cost of that other $150, but it puts them in a bind, and a lot of dentists are saying that they may not, continue to serve Medicaid members if these, sort of barriers continue.
Go back to that for just a second. I want to point out, and I brought the charts with me, so if anybody wants to look at them, they are available online. But the thing that people don't understand about the dental and the vision coverage, as far as the My Rewards account, is that there are only certain services that were ever covered under Medicaid, and those are the only services that could be paid for with the My Rewards account. So when she's talking about $350 worth of work, yeah, there may be $350 worth of work that used to have been covered, but likely there was only $100 worth of that work that was ever covered in the first place. So you're still out of pocket $200, and you think that you go in there being able to pay for your dental services, and then you come out with a $200 bill that you didn't expect because you weren't prepared for that. Because it covers your basic exam, your X-rays once a year, your cleanings twice a year. It covers all of that stuff at a particular cost that it demonstrates for you. It does cover fillings at a limited amount, but it doesn't cover things like dentures that were never covered before anyway. So a lot of people, if it's not medically necessary, it's not going to be covered, and you have no options. As far as classes, yeah, that's the thing. It will pay for the exam, but it doesn't pay for classes. So you're still out of pocket having to pay for your classes anyway, and your My Rewards money doesn't help you. So that's one of the biggest things that we're seeing that people misunderstand about the program is that they thought they would be able to have this My Rewards money. Let me earn all the My Rewards money I can because I can use it to buy my glasses and get my kids' glasses and do all the things that they can do, but they can't.
Yeah, it is very limited. And I think it's hard up front for people to even plan for that, right? You never know how much you're going to need ahead of time. And then the other thing is you might have an exemption for a while. You might be a parent who doesn't have to, who has all the benefits. But once your child is 3 months old, I think it's 3 months, you are now, in the traditional or the Medicaid expansion population, you could potentially lose those benefits. So you need to be thinking ahead and earning these rewards if you absolutely need these services. But people, I think, aren't always aware of that. They hear, oh, I'm exempt, and think that they don't need to worry about it. So there are some lockout periods, too, that we've also talked about. There are 4, and they range from not re-enrolling within this 90-day time frame. It's an annual re-enrollment, missing 2 or more premium payments, not completing at least 80 hours of those work or community engagement activities every month, and not reporting a change in income or family size that would affect your eligibility. And these are all 6-month lockout periods primarily, although some of them could last longer. And the devils are in the deal. But one other thing I wanted to mention is that with not reporting a change, this could actually be considered Medicaid fraud, which is a really serious charge. And we have had state officials say that if someone doesn't report a change on time, their income or their family size changes and they're no longer eligible, and they find out, the state finds out, they will send that to the OIG, the Office of the Inspector General, and they determine whether it's civil or criminal. So that's really serious, and that puts people in a cycle of poverty that they can't get out of. Then there are some on-ramps that you hear about. These are taking classes. These are paying back premiums, or getting those work hours, those community engagement hours in. But these on-ramps are easier said than done.
Let me give you an example of that number 4 that affected me directly. At KIPDA, we had a server changeover, so we all got new email addresses just in the last 6 months. I have a 10-year-old child. Gave birth to him. He's been mine for 10 years. I've been working at KIPDA now for 5 years, and he's always been covered under my insurance. I pay for that as dependent care coverage. So I get this email from our HR office like 2 weeks ago that tells me my child is no longer covered under our insurance. What do you mean? I've been paying monthly premiums. I've been, as far as I know, we've been doing everything. What do you mean he's not covered? They've determined he's not a dependent. So essentially, we got emails sent to our old email accounts that I didn't have access to anymore, telling me that I needed to submit his birth certificate. When I finally got a letter in the mail and literally I had the birth certificate in my hand the day I got the email from the HR person telling me that he wasn't covered. So, okay, I've got the birth certificate. I can scan it in right now and send it to whoever needs to send it to. You can check mark off that he's my child. And, oh no, that takes 3 weeks. So you can submit it today, but it's going to take at least 3 weeks before you can get health coverage back for your child. Which, by the way, I already paid the monthly premium for, and he's not covered. Well, he's really not covered. That's not how this works. He's covered, but you'll just have to pay everything up front and then get reimbursed for it afterwards. Well, I don't know about you, but a pediatrician's visit out of pocket is like $275 at my pediatrician's office. So if my insurance doesn't cover anything and I have to pay that out of pocket for him to get care for strep throat, because I'm waiting on you to verify that his birth certificate is really his birth certificate and I'm really his mom. And that's the kind of stuff you're going to run into with this number 4 down here, not reporting a change. I didn't have a change in my household, but they decided, the computer people, decided by audit that he was no longer my dependent. So how many computer errors are we going to end up with people no longer dependent?
That's a very good example.
All the
I'm
time.
gonna start saying, yeah, that's a very good example. And these are the times when you can just see that people who have the right information, doing everything right, still they struggle to sort of meet these really onerous system requirements. And it's going to be not the exception, the majority of people. So I also wanted to share with you just an updated chart of premium third-party payments. So this chart shows you, based on federal poverty level and where you fall in these different ranges, under 25%, between 25 and 50%, 51 to 100%, and then over 100, you have different premium amounts. And then it also depends on whether you're an individual or your family size. So we did family 4 as an example. You can see how it's broken out by your annual or your monthly premiums. And then the premiums range from $1 for that lowest income bracket up to $15 for the highest income bracket. But the state has been given the option by CMS to increase those premiums up to 4% of household income, up to 4%. And out-of-pocket cost can be up to 5% of your annual income. And so for a premium payment, that could be $55 a month. That's more than a lot of people who are on an individual plan through the marketplace pay. And it isn't something that, is affordable for people who are living.
Also increases over
Yes, it increases over time. So it's really the range that the state has put out is that it goes from $15 up to $37.50 after 2 years. Is that right?
Yes.
But they still have the option of increasing it further. So I think we need to keep that in mind. And then third-party payments. This is something that we think is a bright spot in the waiver where community organizations, nonprofits, provider offices, hospitals can assist people in paying their premiums. They can essentially pay it on their behalf. Now, that's really a waste of community resources because we shouldn't have to be, taking money that we would have been putting into other community programs and trying to use it to pay for people's premiums. But in this case, if it keeps someone covered, it's worth it. So there are organizations who are looking at, potentially paying premiums that when someone can't afford it. There are probably going to be some gaps there too, areas, opportunities to fall through the cracks when, somebody at that doctor's office who was supposed to pay your premium didn't fill out the paperwork or didn't submit it on time or, something happened. There could be a lot of liability on that particular organization, and I think people have concerns about that, but it is something that we want people to know is available. Then I wanted to just briefly talk about the exemptions, and this is something where, again, I think it'd be easier for you to take a look at it on your own computer, but there are a number of categories for exemptions, different types of health conditions or other limitations, the activities of daily living, those sorts of limitations that someone might experience that could get you an automatic exemption. That is again, that's going to be the exception. Most people, if they think that they're eligible for an exemption, are going to have to apply for it. They have to initiate the process by either self-attesting through the Benefind Citizen Connect portal, or going to a provider and saying, you know, I need you to fill out this paperwork for me. And that process, according to the state, can take up to 60 days to process. And during that time, you don't get a grace period where, you know, they consider you medically frail until they determine that you're not. Instead, you have to meet all of these requirements, pay the premium, pay your copays, do the work requirement or community engagement while you're waiting. And we think that there are a lot of people in very vulnerable situations that may not be able to do that. If you're familiar with the 1915C waivers, there are a lot of people who are waiting to get in a slot. So there aren't unlimited slots. And if you don't have one, you don't have anything to do with this. I'm like,
Oh,
No idea.
Good one.
Maybe they were.
Is this still on? Yes.
We'll just leave it off.
Sounds like he's fixing it.
Maybe. Try it again.
Okay. So, in any case, if you have a brain injury and you're waiting on a waiver slot, you have traditional Medicaid. You have to remember all of these things, do them on time, pay your premiums, etc. And we just think that most people are going to lose their coverage before they ever get it. And then if you have a substance use disorder and you want to be determined medically frail, you know, how are you really in a position to meet all these requirements while you're waiting? I don't think that you are.
To apply to be medically frail is a 20-step process with 14 pages of instructions.
That's right. Which came out after the waiver was blocked, by the way.
Cats are fighting again.
Yeah. So this is just a couple of visuals of the process now that they have online. And people can actually start this process now, so that's a good thing. I would encourage people to do it if they think that they meet the requirement or the exemption criteria. So on the screen, they have what we call a gatepost question, which is, are you in good health? Now think about this for yourself, and it doesn't interpret, they don't give you an idea of what that means, whether it's physical, mental, emotional. You know, there's no sort of explanation of what that means, just yes or no, are you in good health? And then let's say you click yes, but really you have a substance use disorder, you have a mental health condition, or you have some other sort of physical, physical issue that you're a victim of domestic
A
violence.
major chronic illness.
Yeah, diabetes. And
It's just a yes or no, but
it's yes or no. And it's, are you in good health? A lot of people, as we were saying earlier, you know, you can feel like you have, you can feel mostly healthy, functional, happy, productive. You can know that, well, I'm not in perfect health. I'm not in perfect health, but I feel like I'm in good health. I feel better today than I did yesterday. I mean, I'm not sick. I don't have the flu. Right. So you can think about this in a number of ways and interpret it very differently. If you say yes, it moves along. If you say no, it asks you a number of screening questions about, do you have these certain diagnoses? Do you have chronic illness? Do you have activities of daily living sort of impediment? And then you can actually say yes or no to each of these specific things. So we've asked the state, just remove that question. Don't have a gatepost question. Just ask every single person, do you have chronic illness? Do you have substance use disorder or behavioral health condition? But so far, the gatepost question remains. So we're telling everybody, answer no. So
did they give you a reason why they asked that game question?
No, not particularly. I think they've acknowledged that it's not the best question, but they haven't agreed to. They say it's, you know, now that it's the system, it takes a long time and a lot of work for their contractors to change it. I said, well, can't you just hide the screen? I mean, or just make everybody an automatic no so that the next questions are asked. We're not asking you to change even the wording. We'd really like you to just remove the question. You know, we're not asking for anything to be moved around. We're just asking for this question to be gone. But no, so far we haven't gotten very far.
Because supposedly if you answer yes that you're in good health, it expedites your application process so that you don't have to go through all those screens and read all that. So that's their intention, is that it would expedite the application process.
It's about, it's a number of, it's not even, actually not even individual questions as much as, yeah, and it's one page, yeah. It's not actually a number of clicks.
Now, if you have to get your provider to go through the whole attestation process, it's way longer. It's complicated.
Yes, and providers, we've been told by some MCOs that they're submitting junk, whatever that means. So that, you know, whatever they're filling out on the form is not enough to, you know, to meet the criteria. And so they're having to get back in touch with patients or get more documentation. So yeah, this process is by no means, you know, sort of just based on whether you meet the criteria. So the status of litigation, just so that you know, of course, the waiver was blocked from implementation, so it's not in effect right now, although you wouldn't necessarily know that if you went to that fine. There are a lot of, the logos are still up. They're still encouraging people to earn my reward credits, and there's still just a number of things that are sort of being, I guess the way that they're communicating about it is that it's kind of on hold. But technically, it is not legal and it is in no way implemented. But I think people have a different impression, and there have been no notices to consumers to say that this happened other than online on the website. So if you happen to go to the website, even though that it exists, you might see, oh, the waiver was blocked, this is on hold until we get reapproved by CMS. But nothing has gone out in mail or email to people, even though they were getting a number of notices before pre-implementation. And so that is the last thing that they probably, you know, have in their mind, right? So in any case, that's the status, and the case is staying with the same judge. So now that CMS has decided to go through the re-approval process, which is why we have a new 30-day comment period that Dustin was talking about, once CMS reapproves it, which we assume that they're going to do, we know that that's their intention, they may try to justify it differently. They may, you know, take a few different steps than they did the first time to try to kind of address some of the judge's criticisms of them not following the process. But we don't think that they'll be able to prove that this improves access to care or health outcomes or meets the basic scope of the Medicaid program, the intent, which is, again, to furnish health insurance to low-income Americans. But we assume that it is reapproved, or we know it is, that there will be an immediate challenge to it, so it'll be back in the courts. And then one issue with, I mentioned the copays and the benefits. The copays are now optional again. MCOs have the option of charging, although some people are still experiencing some issues with that. Not a lot, but a few. And that happened because, again, the state didn't follow the rules. They didn't follow the process. They didn't notify anyone. But that doesn't mean that they can't do this again. So nobody should be comfortable thinking, well, you know, we got our benefits back. Nobody, you know, copays aren't being charged anymore. People are okay. In fact, I would speculate that if this is reapproved and is challenged again in court, the state will be ready this time to follow the correct steps to reduce these barriers or reduce these benefits and to impose copays in a way that is legal. So what comes next? You know, we have a lot of work that we've been doing to, one, raise the voices of Kentuckians. That's why we're consumer advocates. We think that everyone should have a say in the decisions that affect their health care. So we want people to be heard. We want people to be part of the process. We want transparency. So we participated in that public comment period and collected comments. We do a lot of education and try to make sure people understand how this will impact them and what options that they have to speak up, to be heard. We encourage people to talk to their legislators. Something that we're working on with KCIPDA is a public dashboard where we will actually be collecting. We're going to do a survey where we're asking outreach workers like you, like a lot of folks in this room, to help us identify barriers that your clients are experiencing, people in your community. So report those barriers to us, and then as we see trends, we will report those trends to the state and work with state agencies or work with our partners who are better working relationships with the state agencies to try to, address some of those trends and to find either resolutions to the issues or workarounds, like Kellie was talking about. We're doing a lot of workarounds these days, but ways that we can reduce barriers for people. And then this public dashboard will include some of those examples of things that people are experiencing, but also administrative data, things like enrollment data, and how that's changing month to month, and who it's changing for, what members of the population, kids, pregnant women, parents with dependent children, other Medicaid members. Also looking at, access to services, utilization of services. So seeing how things are changing based on these new policies and really being able to follow that closely and track it. And then looking at administrative red tape and where these new barriers are in place, what is the impact there. And then we're going to be also working with legislators to push for a permanent solution to some of these benefits that have been that are considered optional federally. They are technically optional, but states have a choice to make them permanent, to make them part of the Medicaid package for everyone. That's the choice the state has made up until now. But because we have an administration that wants to potentially reduce these benefits in the future, we're going to be working with some legislators to pass a bill that would make them mandatory for all Medicaid members. So those are just some examples of things that we're doing. We're also going to be doing focus groups with consumers and with application assisters, with outreach workers, community health workers, to really drill down into some of these experiences that they're having and the barriers that they're experiencing, so that we can learn more about that. So that's it, yeah. Hopefully that wasn't too much. If you all have questions, we're always happy to answer them either today or you can contact us with email addresses.
Okay, so
I'll turn this back on now. I'm going to give you just, I don't have any slides to show you. I want to share with you some information about some things that we need to be continuing to do as we're moving forward. The latest forecast from the state as far as what the assisters are hearing is that they expect a reapproval before October 1st. If that reapproval happens before October 1st, then they expect new implementation date of January 1. Because that's a 90-day window for the implementation period. They have to send out 90-day notices that there's going to be a change to the Medicaid services. So that is the current expectation and timeline of our state administration. So be aware that they fully expect this to move forward regardless of whatever legal situations are taking place. So that's one first thing you need to know is they expect it to move forward, and by January 1st, you will begin implementation of this program. One of the other things you need to know is, as I mentioned, there's that 20 step procedure to apply for medical frail status. 14 pages long. This is available easily, and I can send it to Mona, and Mona can send it out to everybody as a link to the document, so that you can share this with anybody that you think. And the reason you need to go ahead and share this is because if they go ahead now when they're going to the doctor and begin to get their medically frail status applied for and accepted, that they reach the score with their MCO that they are going to be considered medically frail, the 12-month period of their status actually doesn't begin until their area becomes Kentucky Health necessary. So they still get the benefit of their 12 months of coverage as a medically frail status. But what it does do is a couple of things. One, it goes ahead, if they're visiting their doctor, they can go ahead and get the paperwork process started and get all the steps done so they're not having to wait at the beginning of implementation of this. Two, it also allows the state the opportunity to see how many people that they are considering in the past thought that would be paying premiums and would be paying into the system and doing things, to see how many of those people actually are medically frail. And just had never filed that status before or never declared that status before. So you want to go ahead and encourage anybody that you come encounter with, if you believe that they are medically frail or would meet any of those medically frail status requirements, go ahead and have them begin their application and get that going. It's important that they do so that it's on file and ready to go.
Is that for people under 65?
Yes.
Yeah, can I add one thing to that? Sure. So something that we learned after the court decision again, whenever the state reduced those benefits, was that when you have two different benefit packages for Medicaid members, then, and one is considered the alternative benefit plan, so that's the one with the reduced benefits, then you have to have a medically frail category, even if you don't have a waiver. So if in the future, let's say the court blocks this again and we don't have implementation of Kentucky Health, but the state decides to eliminate these benefits again for the Medicaid expansion population, they can still get that medically frail exemption and not have to, they wouldn't lose those benefits and they wouldn't have to pay copays. So it's important regardless.
So if there's any questions about who qualifies or how to qualify, you should be able to identify that in the document. There is a very small, actually just really 2-paragraph process about chronically homeless and declaring yourself chronically homeless. This also gives you a 12-month exemption, but I want to explain to you that there's a lot of people that are chronically homeless that we don't necessarily consider chronically homeless because they're not sleeping on the streets. But if you don't have a bed that's yours in a home that is yours, whether it be an apartment that you're paying rent on or a regular place that you stay, a house, if you're staying on a friend's couch for weeks at a time, that's homeless. And a lot of people don't think, oh, I've got a roof over my head, I'm not sleeping in a car, I'm not sleeping out on the street, so I'm not really homeless, but they are. So the process to become declared chronically homeless is a bit simpler, but also gives you a 12-month status. So I want to encourage you to question the people about what their true living situation is so that you can understand if they truly are chronically homeless and should be applying for that status as well. So, the hidden homeless.
And
That's
then
right.
there's also interpersonal violence, which is another category that is no longer considered medically frail. Temporarily vulnerable refugees and victims of domestic violence or interpersonal violence fall into that category.
That is true. The refugee status is actually only good for being exempt from the waiver for 12 months from the date of when they enter the country. So truth is if they enter the country, they have a petition starting technically today, even though this is not implemented, it would go until September 4th of next year. So they get 12 months, even if the Kentucky Health doesn't begin until January. That makes sense. So at least you have your refugee status there, that they have a little bit of a break to supposedly learn English. But it's 1 year from the date that they enter the country, so that they can get a job and work and function. It is correct that the majority of the people who are on Medicaid in our area are working people. They are below income working. Some of them are actually in decent jobs.
Come on.
I have a teacher voice, or I can use the other one.
So those are a couple things that I want to point out as far as direct impact of what you need to be doing in your community. The next thing I want to talk about briefly is the fact that a lot of this, while traditionally any of the Medicaid work that we have done has gone through the DCS office, all of this work requirement and community engagement stuff actually is not going to the DCS office. As of January 1, all of the SNAP work requirements that were tied to SNAP benefits began going through our workforce development boards. It wasn't largely advertised. It wasn't talked about much. It just, the transition that happened, that it was kind of behind doors and nobody knew about. In fact, I didn't know about it until 3 weeks after it started, and I called to get something done. They're like, we don't do that anymore. What? So we had to backtrack and figure out, oh, that's now with the workforce development boards. So there is on your local workforce development board a link on their homepage typically to where you go to report SNAP work requirements. Anybody who's reporting SNAP work requirements, that's the work requirements that also apply to the community engagement portion of this. But those workforce development boards are going to be solely responsible for Citizen Connect. So uploading of documents, uploading of pay stubs, all that stuff that we've been able to get support and help from through the DCS office and through that customer support line that they can call and talk to on the phone, out the door. Can't do that anymore once you start Citizen Connect. You will have to call the Workforce Development Board. There is not like a call center support staff that's going to help with that. As far as the entire state, one number that you call, they're going to have to know their Workforce Development Board number that applies to their area and call the right office. Now, they may be able to go into the unemployment office, what their area considers their unemployment office, and get some assistance and get some help. Supposedly there are job coaches that are going to be located in every county at some point during the implementation of this process. But they're not there yet because those people are still being hired and are on hold right now because they're not being paid to do that because this whole process is on hold. So you got to get people in there hired, trained. I want to use a demo here. Evidence. 375-page manual. 2 days, literally 16 hours of in-depth training spent for me to understand just the changes from the previous Connect system that I worked in to the new Connect system that I work in. And this doesn't even include Citizen Connect because we, as a sisters, aren't allowed to touch Citizen Connect and have no ability to help a person who needs help in Citizen Connect. I can tell you which button to push. I can sit there and say, oh, if I were you, I would do this. And if I were you, I would push this button. But I can't actually help them on the computer, type anything. People who can't read, I can't help you. You have to go to the workforce development office and sit with a job coach and help you. So there are a lot of barriers there that we haven't considered in the implementation of this process. That you need to know who to call, where to send them, because you can send them to me and then I'm going to have to send them somewhere else. And they're just going to get frustrated and irritated and give up, throw their hands up in the air and say, I'm just done with this whole mess. And that's the loss of coverage to all of these people that we consider, they're just done dealing with the technology of the mess and the reporting requirements. We work a lot with the previously justice involved population, those who've been in jail, could be substance abuse or substance use disorder issues. It could be small misdemeanors or not paying child support and those kinds of things that land you up in jail oftentimes. We deal with a lot of those people and helping them to get enrolled in Medicaid and make a healthy reentry into society. Our number one barrier with that population is ID verification to even get their application started. And that's not limited to just the previously justice involved. It is across the board. You have to be able to answer certain questions about where you lived or what car you owned in what year, what bank that you had a loan through. If you have a loan and you don't have a credit history, none of that can be verified. So then how do you get your identity verified? Well, it seems as simple as being able to upload your driver's license. But in Kentucky, we can't just upload a driver's license because that's not considered a valid form of identification.